I'm a urologist in Brooklyn, New York, and as the son of a carpenter, I typically tell people that I'm your favorite neighborhood plumber, body plumber, that is. Today, we're going to focus on prostate cancer. And if you're newly diagnosed with prostate cancer, we'll discuss what you need to know. This isn't just for folks who've been diagnosed with prostate cancer, but this is also for your family, friends, and loved ones. We'd really like to generate discussion about this topic and make sure that everyone is on board. I have no financial disclosures. However, some slides were used with permission from the American Urological Association. You may find this funny, but this is what happens when I look at my phone and I get an alert about something that's either jarring or fascinating. And I got some jarring news recently. There was a New York Times headline that Dexter Scott King, the younger son of Martin Luther King Jr., died at the age of 62 after a battle with prostate cancer. I found this shocking and surprising because I lost my own father to prostate cancer at around the same age. And whereas I thought that we had come a long way in managing this disease, this headline shares that we haven't come as far as we think we have, and there's a lot of stuff to do. And I hope that there are lots of discussions like this one that we're having taking place all around the United States. I like to start off by, thinking about why. This is a book by Simon Sinek that actually changed my life. It made me think about why I do things, how I do things, and what is the result of the things that I do. And he proposes this golden circle concept where at the core of everything is our why. And then there's our how, and there's what we produce. So let's focus on why we're here today and why this topic is so near and dear to my heart. Please forgive the quality of this photo, but this photo is actually over 40 years old. And this is a picture of my father and I. I was 2 or 3 at the time, sitting on a sofa. And again, I mentioned I lost my father when I was 15 years old, just at the beginning of my senior year of high school. And it really had a direct impact on the path I took in life. And it's one of the reasons why I'm here now speaking with you. My journey led me to the Memorial Sloan Kettering Cancer Center because I wanted to learn the most up-to-date techniques to treat prostate cancer, especially in men from underserved communities who may not have the same access to care. After a stop there, I settled in Brooklyn, and I'm a urologist at SUNY Downstate Health Sciences University, and I also work at Kings County Hospital Center. Hence the nickname I gave myself as your favorite neighborhood Brooklyn body plumber. But I know it's typically never good when you assign yourself the nickname. That point is not lost on me. So let's get to why prostate cancer is important in 2024. This year, approximately 299,000 men will be diagnosed with prostate cancer. The typical risk of being diagnosed with prostate cancer is about 1 in 8. That risk rises to 1 in 5 if you have a family history of prostate cancer. And about 35,000 men will die of prostate cancer this year. And again, the risk is higher in Black men compared to white men. The risk is about 1 in 6 1 in 6 for African American men. So not only am I a practicing urologist, but I'm someone who's in a high risk category because I'm African American and because my father had this disease. So when you look at the estimated number of new cancer cases in the United States in 2024, prostate cancer is the most commonly diagnosed cancer in men, and it's the second leading cause of death. And if we think about things over the last few decades, there was a rise in the diagnosis of prostate cancer when screening was introduced in the mid-90s. It sort of dropped, and it's been on the rise again. So this is a very important topic, and I'm glad that we're here today discussing this. There are a few learning objectives for this discussion today. One, I'd like you to walk away with an understanding of what prostate cancer is, We'll discuss the Gleason scoring system, the staging of prostate cancer, treatment options, and hopefully you'll have an idea about whether or not you should seek a second opinion before you make a final decision regarding therapy. Let's start off by discussing what exactly is the prostate gland. The prostate gland is a little walnut-shaped gland that lies between the bladder and the penis. Actually, the urethra sort of goes through it, and the prostate actually produces fluid that bathes semen. I mentioned PSA level before, and you may have heard about PSA, but what exactly is PSA? PSA stands for prostate-specific antigen. It is a protein produced by both normal and cancer prostate cells. And it keeps semen in liquid form so sperm can swim. When you think about screening for prostate cancer, in 1994, the FDA approved PSA for prostate cancer screening in conjunction with a digital rectal examination, and the typical cutoff level is 4. However, there are men with quote unquote normal PSA levels who are diagnosed with cancer. And there are also folks with high PSA levels who do not have prostate cancer. So, how do you diagnose prostate cancer? Typically, you have to do a biopsy. So there's a rectal probe that goes into the rectum, and it allows us to take some pictures of your prostate. And then we use a needle to do a biopsy. When you think about a prostate and what things look like, I'm going to take you on a little adventure with me. And just imagine that you're at home with me and we're looking at things under a microscope. We're looking at things, they're magnified, and I will share how we get from a normal prostate cell to a cancer cell. And this may help you make sense of the whole Gleason scoring system. So in the upper left here, we have a normal prostate. And then, cells kind of transform and you have prostatic intraepithelial neoplasia. Essentially, they're just some changes. We have localized cancer, and then we have very bad cancer that develops into metastatic disease. And if you're an architecture buff, please pay attention to the architecture of the various cells around the gland. You can see as we go from normal prostate to cancerous prostate, the architecture changes. And with these changes in architecture, we've observed that prostate cancer cells behave a little differently. So this Gleason scoring system. So going back to architecture, the Gleason system is essentially a way to score cancer based on what cells look like. And there are some terms that are listed here: well differentiated, moderately differentiated, and then poorly differentiated or anaplastic. Let's just think about order versus disorder. So with lower Gleason scores, they're cancerous cells, but they're still order. Whereas once you get to Gleason pattern 5, there's more disorder. And the Gleason score that one is given, you may have seen this on your biopsy. You might have a 3+3 or 3+4 or 4+3. What those numbers mean are the first number is the primary predominant cancer that's found within your prostate. And the second number is the second most prevalent type of cancer found within your prostate. So you typically get a score which adds up to a number ranging from 6 until 10. So this is what a normal prostate looks like under the microscope. I don't know if you enjoyed science class or not, but I'm taking you back. So this is what a normal prostate looks like under the microscope. You can see they're separate glands, there's space in the middle. You see these little dark spots, which may look abnormal to you, but they look pretty normal to me. This is what a normal prostate looks like. Now let's go to some conditions that may be confused with prostate cancer. You might have heard of something called benign prostatic hyperplasia. Father Time often isn't good to us. And you may notice that as you've aged, you have to go to the bathroom more, you have to wake up more at night to pee, your urinary stream may become a little weak. Oftentimes, that's because of benign prostatic hyperplasia. So there are changes, but these are benign changes, which lead to an enlarged prostate. This is what cancer looks like. When we have a prostate here in this area, you notice the typical architecture of the prostate gland. It looks like a gland, but it looks abnormal here. This is what prostate cancer looks like when you're just looking at it with your naked eye. Now let's look at it at the microscopic level. And I actually have to thank a dear friend of mine, Dr. Stacy Loeb. She's a practicing urologist. She's done a great bit of research, and she sort of helped me to better understand the Gleason scoring system many years ago. And she did this by comparing prostate cancer to donuts. Consider this. You're going to work in the morning, you're picking up some donuts for folks that you work with, you get a box of a dozen donuts. All of the donuts are circular, the hole is poked out in the middle, they're nice and round, the glaze is there, and everything looks fine. That's a normal prostate. So say if, on the way to your car or just walking to work, you bump into someone and, the edges of the donuts are crushed and they sort of come together. That's what prostate cancer looks like under the microscope. Say if you drop your box of donuts, then, they may not look the same, but they're still donuts. That might be someone who has Gleason 4 cancer. And say if you put the donuts on a chair and someone sits on the box of donuts accidentally and everything is smashed together and it doesn't necessarily look like a box of donuts anymore, it just looks like a box of stuff. Those are those Gleason 5 cancers, which are very aggressive. So think about it. I mentioned architecture before. The Gleason scoring system merely describes what the cancer cells look like under the microscope. And we know that these different Gleason score cancers behave differently. Hence my donut comparison that I borrowed from Stacy Loeb. Thank you, Dr. Loeb. So again, I just wanted to show you a picture of a normal prostate underneath the microscope. So this is normal prostate. Now I'm going to show you what these different Gleason scores look like. This is Gleason 3 cancer. This is normal. This is Gleason 3. You can see that things look a little different. This is Gleason 4, much different. Gleason 5, you just got a bunch of cells under the microscope. You can't make out whether or not they're formed in glands or not. And this is one of the most aggressive prostate cancers that we have with a high potential to spread. So that's the Gleason scoring system. Sorry to take you down the rabbit hole of architecture and take you back to science class, but I think it's important that you understand what's happening and why we look at things this way so you can make the best decision for yourself. So let's talk about staging. So, some people may throw out terms. They may ask and say, hey, well, do you have stage 1? Do you have stage 2? Do you have stage 3? Or is it stage 4? Is it metastatic? What does that all mean? With prostate cancer, staging refers to how the cancer is detected and whether or not it's spread outside of the prostate. So with T1 prostate cancer, it's identified by a biopsy, maybe done because of an elevated PSA level, but you can't really feel anything. With T2 prostate cancers, it can involve one side, one lobe of the prostate, or both sides, and that is T2 prostate cancer. When you have T3 prostate cancer, that means that the cancer is beginning to break through the capsule of the prostate. And so you may feel it on the surface. It could spread to the seminal vesicles, which are these little things that are attached to the prostate and they actually look like rabbit ears when you take them out. Um, and also, this refers to prostate cancer that starts to invade the bladder neck. Because remember, the prostate is essentially attached to the bladder. And then when you get to T4, the cat is really out of the bag, so to speak. The tumor is spread to tissues next to the prostate. It can spread to the rectum or it could spread to the floor of the pelvis. Now, that's the T for tumor staging. And then you have node status. That helps us to describe whether or not the prostate cancer is spread to the lymph nodes. There are some times when we know, and other times when we don't know. So you may get assigned a number of N0, N1, N2, or N3, depending on whether or not the prostate cancer has spread to the lymph nodes. And then there's metastatic disease. Metastatic essentially means that the cancer spread to other portions of the body. And so there's typically M0 or M1, which means that the cancer is spread to lymph nodes outside of the normal path of the prostate, or it's spread to the bones or other organs like your lungs, your liver, or even your brain. Believe it or not, if prostate cancer is not caught in time and managed, it can even spread to your brain. So, okay, we discussed the Gleason score, but the thing gets a little complicated because there are Gleason scores, which I mentioned, and we have recently started to describe things in various groups. So there's a Gleason grade group. And then based on your grade group, you will be deemed low risk, intermediate risk, or high risk. Everyone's a little different. And so it's important to kind of construct your puzzle with your doctor so you can determine your Gleason grade group and also what risk category you're in. Your risk category will determine the options available to you. So there are different organizations that classify risk in different ways. I'll highlight two of the larger groups, one being the American Urological Association. So say you're a low risk person, if your PSA level, that prostate specific antigen level, if that level is less than 10 and you have grade group 1 and you have stage T1 or T2A, you're low risk. And if you're a low risk person, typically we watch those cancers. We do something called active surveillance. Now, say if you're someone with intermediate risk, your PSA may be between 10 and 20. You may have, T2B or C disease, and you can kind of have either favorable or unfavorable intermediate risk disease. Depending on which one of these you have, you might opt for surgery, radiation, or another sort of treatment for your prostate cancer. And if you're high risk, then that's another conversation. Again, these things are done to help classify you into various categories and to help you make the best decision for yourself. So when you meet with your urologist or an oncologist, please ask, what is my risk stratification and how does that impact the options for treatment that I have? This is another organization's risk stratification, the National Comprehensive Cancer Network. And they separate things into very low risk, again, favorable intermediate risk, unfavorable intermediate risk, high risk, and very high risk. Again, these are all just different categories that we place people in, and we use this to help you make the best decision for yourself. Now, should you rush to make a decision when diagnosed with prostate cancer? I say no, absolutely not. We are here to help you make the best decision for yourself. And the best thing that you can do when walking out of the doctor's office when you've been given a diagnosis of prostate cancer is to do a little bit of research on your own. I would suggest that you talk to different people. Maybe there are other people in the family who have had prostate cancer. Perhaps you may have friends. And there are a number of prostate cancer support groups out there. And there are a number of men who are open and willing to talk about their experience so you can make the best decision for you. Now, there's something called shared decision making. And this is sort of a collaboration between physicians and you. This is a shared decision process. And also, I think that it's good to involve a loved one in your decision making, whether that's a spouse, a partner, a dear friend, another relative, someone who can help you process all of the information coming in and to ensure that you make the best decision for you. I'll tell you, sometimes when you get bad news, when you hear the C word, you hear that you have cancer, you may totally space out and not hear anything else that the physician says. I think it's best if you have someone with you who can listen and take notes too, and ask the questions that you may need to ask, but you may forget to ask. So let's go into detail about shared decision making. All prostate cancer treatments carry risk. There are risks to your urinary, sexual, and bowel function. And these risks generate a lot of fear, and they lead to some people delaying treatment, which is not good. There are risks posed by the cancer, and I think that it's important to discuss these risks to facilitate a shared decision-making approach to management. These are some things that you should consider when making a decision regarding treatment of your prostate cancer. Your life expectancy. It may sound like a weird topic, but your approach to prostate cancer should vary if you're a person in your 40s or 50s versus being someone in their 70s or older. Another thing that you might want to consider is other medical conditions that you may have. Other medical conditions could impact how high risk you are for developing side effects to therapy. And also, I always stress the importance of family and loved ones. You and your family's preferences are important. And it's important to keep all of this in mind when making a decision regarding treatment for your prostate cancer. And one thing I would do too, I would ask for an individualized risk estimate of recurrence, because your risk of recurrence for prostate cancer may be different than someone else's. And there are various tools that we have where we can plug in information and give you a pretty accurate description of your risk of the prostate coming back or even spreading to other areas. You know, we have to deal with things and balance things. So considerations for choosing the appropriate treatment for localized prostate cancer. So at the heart of things, we want you to have the best outcome, the best possible outcome. And so we want to maximize survival, but hey, quality of life is important too. So when thinking about the survival, of course, we want to reduce mortality. We want to control the cancer. We want to avoid you developing a secondary cancer, and we want to maintain and or improve your overall health. However, on the quality of life side, it's important to think about your recovery, and we want to do things that preserve your urinary function, your bowel function, and your sexual function. I know sexual function may be a taboo topic for some, but it's something that we should really discuss openly. Please have this discussion with your doctor. Please involve your spouse or your partner in this discussion, because prostate cancer can indeed impact your sexual function. However, where there's a will, there's a way. And there are things that we can do to counteract the impact that a diagnosis and treatment for prostate cancer could have on your sexual life. So let's get to treatment options for prostate cancer. So again, There's active surveillance where we essentially watch your cancer. There's some prostate cancers which are very aggressive, which spread, and there are others which are almost like nuisance cancers because you know that they're there, but they don't typically spread. And this is someone who would fall in the low risk category. We do active surveillance. So it's active monitoring of the prostate where we'll see you every few months. We'll do an exam and we'll do a PSA level. And periodically, we may repeat a biopsy or get an MRI just to see if the characteristics of your cancer have changed. And this is one thing. You can kind of switch and jump from one category to another. In some instances, you may start out as someone who begins on your active surveillance journey, but things may change and you may opt for surgery or radiation in the future. And that is totally okay. So let's talk about surgery. So men in the intermediate risk category and some in the low risk and even in the high risk category may consider surgery straight away. And we do surgery using different techniques. There's robot assisted surgery, there's laparoscopic surgery, and there's traditional open surgery. And the goal of surgery is to remove the prostate and all of the cancer cells. But it's important to note with surgery, we remove what we can see, but you can't see everything with the naked eye. So even if you have surgery, there's a chance that prostate cancer can come back and you have to continue following up with your doctors after surgery. Then there's radiation therapy. We apply radiation to the prostate in hopes of killing the cancer cells. And there are a number of ways to deliver radiation to the prostate, and we even implant radiation seeds. So this kills prostate cancer cells, but it does not necessarily remove them. And again, even after radiation, prostate cancer can come back. So there are other treatments. Some men opt for cryotherapy, not very common, but it happens. There's something called hormone therapy for prostate cancer too. And I want to relate this to food, not to donuts though. Let's leave the donut analogy behind. But let's think about food. So we all require water and food for sustenance to grow and to thrive. Prostate cancer cells work in the same way, actually, but they don't feed on food. They actually feed on a hormone that men and women both have. Men tend to have a bit more of it than women, but testosterone. So prostate cancer cells feed on testosterone. And the whole theory behind hormone therapy is that you do things to disrupt the body's production of testosterone in hopes that you can starve and better control prostate cancer cells. There are times when men have surgery and they have hormone therapy after. And there are times where we give hormone therapy along with radiation, because if you look at someone 5 years from now, depending on your risk category, you may be better served by radiation along with hormone therapy. I won't get into the weeds now with the discussion, but this is something to explore with your doctor. So, should you get a second opinion before you make a final decision? Absolutely. I think it's a smart thing to do. Just think, there are certain steps that once you take them, there's no turning back, surgery being one of them, radiation being another. I think it's important for you to get a second opinion, talk to someone else, present your numbers, present your stage, and gather more information. Our aim as physicians is to empower you to make the best decisions for you and your family. So, a couple of take home points for today. Prostate cancer is common. Prostate cancer is curable. The side effects can be managed, even the sexual ones. Please do not let fear of side effects prevent you from seeking therapy. Get a second opinion before making a decision and talk about things with your friends and family. Many thanks for your time. And, you know, the folks at Zero, myself, We're all just trying to work together to make the world a better place from the prostate cancer perspective. Thank you.